Hi, everyone. Welcome to the Journal of the American Society of Echocardiography podcast in collaboration with the CSE Live Journal Club. My name is Dr. Ahmed Johri, and it is my pleasure to welcome you here today. I just want to talk to you a little bit about this collaboration. So the idea was that we would work together with a JASE podcast to reach out to both Canadian and American audiences and work together to talk about the latest in echocardiography research and the latest publications in the Journal of the American Society of Echocardiography. So it's my great pleasure to introduce our Editor-in-Chief, Dr. Michael Picard. We're going to hear a few words from Dr. Picard, and then we're going to hear a little bit about our speakers and panelists, and then dive into our presentation. Dr. Picard, welcome.
Great, thanks, Ahmed. And thanks for doing this again. I think last month was quite successful doing the combined meeting. So this will be another interesting one. So today we're going to discuss a paper that was recently published that uses contrast ultrasound in heart failure patients. And contrast is obviously an important part of the toolbox of echocardiography. And yet we don't see many papers published on contrast these days. And the ones we do, I think primarily are on perfusion. So the old-fashioned indications or the primary indications for LV opacification, border delineation, it's been around for so long that we just don't see too many papers on it. And so I think that's one of the reasons we should take a look at this paper, because this may have important applications for most clinicians. A lot of the perfusion studies, excuse me, Tom, for saying this, but I think they are probably limited to a more select group of clinicians and investigators, but certainly contrast for LVO is broad and can be used by everyone. So I think that's why it'd be worthwhile discussing this paper today. Most of the papers on LVO and contrast talk about improved reproducibility of ejection fraction measurements and wall motion assessment, but this one delves into outcomes, and it's very rare that we get to talk about outcomes with contrast. And this one also, I think, is interesting because I think the authors thought a little bit outside the box when sort of how to define outcomes. So they use some outcomes that we might not have initially thought about. So for all those reasons, I think it'll be an interesting discussion.
That's great. Thanks, Dr. Picard. Could you go ahead and introduce our panelists for us first, Dr. Porter and Mary Bremer?
Oh, sure. So we have two great speakers today to discuss the paper. Mary Bremer is from the Mayo Clinic. She is one of the premier educators in the sonography world and runs a great school there. It's been involved in a lot of educational initiatives, both at ASC and many other initiatives. Our other panelist is Tom Porter, who is the Hubbard Chair at the University of Nebraska. He's the chair of cardiology there. And Tom has been a leader in contrast echocardiography in all aspects, and particularly in perfusion, in sonothrombolysis, really a lot of really novel approaches to the use of contrast agents, and also just early on, just helping us understand the basic physics of how these bubbles work and why they work and why we should be using them. So we've got some really two great clinicians who will help us with the paper today.
Yes, and I've been really impressed by Dr. Porter's presentations at the Chicago Bubble Conference that I've attended with him over the last few years, and his amazing work in sonothrombolysis. So it's perfect to hear his commentary on this paper. And with respect to our actual presenters from CSE, we have Michael Hammer, who is an Echo Fellow, and he was a cardiology fellow at University of Toronto. He did his BSc at Western University. He has interests in education and community care, so I'm really delighted to have Michael Hammer here. And then, of course, we have Dr. Shaheeda Ahmed, who is an associate professor at University of Toronto. She's actually done two fellowships. The first was an echo fellowship at McGill, and then she went on to do a clinical trials fellowship with a TIMI group at Harvard. And her focus has been on education. So Dr. Ahmed, you are our first speaker, and I'm going to let you take it away. If you can go ahead and share your screen and present today's paper.
Thank you for that generous introduction. I'm just going to share my screen. Okay, terrific. Can you see that?
Looks good.
Wonderful. So again, heartfelt thanks to the organizers for providing us with this wonderful opportunity to collaborate with both the CSE and the ASE, and to all of you for taking the time out of your lunch hour to join. So we have no relevant disclosures. Heart failure is the fourth leading cause of hospital admission in both the US and Canada. Admissions cost. In the US, expenses are high based on data from the Medicare population. In Canada, the estimated annual cost of hospital admissions with a primary diagnosis of heart failure was $482 million in 2013, projected to rise to $720 million in 2030. In Canada, the temporal trends show that both visits and length of stay in hospital related to heart failure are also rising. So when admissions with heart failure as a secondary diagnosis are included, projections swell to $2.8 billion per year. American and Canadian guidelines recognize echo as a central diagnostic test in heart failure management. The most common indication for inpatient echocardiograms is heart failure, but a high proportion of studies are suboptimal. Ultrasound enhancing agents can improve LV assessment. ASE guidelines recommend contrast use when 2 or more LV segments are inadequately visualized. More accurate assessment of regional wall motion abnormality is necessary, or quantification of LVEF is necessary for prognosis or management. So the investigators at Piedmont Hospital in Atlanta developed a transthoracic echo protocol that used contrast routinely on all admitted heart failure patients during their first echocardiogram, irrespective of image quality. They evaluated the impact of the standardized protocol on A, repeat transthoracic examinations, and B, length of stay of index heart failure admission.
So the investigators retrospectively analyzed 9,115 heart failure admissions with at least one echo between January 2014 and December 2017. Prior to the study period, they developed, and in 2012 to 2013, they implemented a protocol of routinely using contrast on all of the first inpatient studies performed for heart failure. The protocol used standard echo image acquisition sequences, and contrast was administered by a small incremental IV boluses, followed by saline flush. Not all eligible patients received contrast due to the listed reasons here. So known hypersensitivity, consent issues, and lack of resources to inject contrast. Charts were individually reviewed and assigned to the contrast group or the non-contrast group based on the use of contrast during the initial echo. Repeat echoes performed during admission were then classified as either justified or unjustified based on this preset criteria. So a study was considered justified if it occurred at least 14 days after the first echo, if it followed a cardiac procedure, if it was performed as a part of a clinical trial protocol, if it was done to evaluate or reevaluate pericardial or pleural effusion, or if it was following an acute change in clinical status. A study was considered unjustified if it did not adhere to the above criteria, or if it was done solely to reevaluate LV function. So the investigators compared the incidence of repeat unjustified echo between the contrast and non-contrast groups. They also tried to determine what impact image quality of the baseline echo had on frequency of repeat echo testing. So in order to do so, one experienced reviewer manually classified images as optimal versus suboptimal. Image quality in patients who underwent unjustified repeat echoes was compared to a random sample of patients who did not have repeat testing.
A total of 9,115 admissions were eligible over the 4-year period. Of these, 5,600 received contrast during their first echo. 3,515 did not. Although the intent was to apply the protocol to all heart failure admitted patients, not all patients received contrast, mostly due to lack of resources to inject contrast, and less so for known hypersensitivity or issues with consent. Over the 4-year period, overall ultrasound enhancement agent use increased from 50.4% to 74.3%. The total number of unjustified repeat echocardiograms remained low, 1.3% and 0.9%. This figure nicely illustrates that over the study period, contrast use increased steadily over time, and concomitantly, the rate of repeat unjustified transthoracic echo studies dropped. Over time, contrast use during repeat transthoracic echo studies also increased. Overall, the study population had a male preponderance with a mean age of 68 years and mean LVEF of 43%. Table 2 summarizes the key demographic features of the contrast and non-contrast groups. Statistical differences are highlighted by the stars. Compared with the non-contrast group, the contrast group was younger and had proportionately fewer women. The LVEF was more often reported. There was a lower mean LVEF. There was more heart failure reduced EF, and the BNP was higher. The two groups were matched for New York Heart Association class and troponin level. Contrast use was consistent across the time of day. The results of repeat transthoracic echo testing are shown here. Overall, 10.2% of all studies were repeated, 9% in the contrast group, 12% in the non-contrast group. As shown on the right, nearly 90% of the total repeated studies were justified. 11% were not. Among unjustified repeat transthoracic echocardiograms, the leading indication was LV function. The rate of unjustified repeat transthoracic echocardiography was significantly higher in the non-contrast group, 2.3%, versus the contrast group, 0.4%. Not using contrast on the initial transthoracic echocardiogram, irrespective of image quality, was associated with a more than a 5-fold increase in a repeat unjustified transthoracic echo.
Impact of baseline image quality on repeat unjustified echoes is shown here. Among repeat echo studies categorized as unjustified, the contrast group had more suboptimal images at baseline than the non-contrast group at 66.7% versus 37.5%. Despite having more quality baseline images, the non-contrast group still had more unjustified echoes. Interestingly, in a random sample of 410 patients without repeat echo, the non-contrast group still had better baseline images than the contrast group. And so to summarize, there were more good quality first echocardiograms in the non-contrast versus contrast groups, whether studies were repeated or not. This is just a figure provided by the authors, which demonstrates the use of contrast to improve image quality in studies with suboptimal, intermediate, and good baseline images. The effect of image quality on the incidence of repeat unjustified echoes is shown here. So there were 104 patients that had unjustified repeat echoes. A random sample of 410 patients without repeat echo is shown. When stratified by image quality, 31.3% of suboptimal echoes were followed by an unjustified repeat, whereas only 15.8% of optimal echoes were followed by an unjustified repeat study. And therefore, suboptimal image quality on the baseline echo significantly increased the likelihood of repeating an unjustified echo by a factor of about 2.4. The length of stay analysis is then shown here. So both the mean and median length of stay were significantly shorter in the contrast versus the non-contrast group. In a multiple linear regression analysis controlling for the length of stay prolonging factors outlined by the NIS, contrast use was associated with a significant reduction in length of stay of 0.47 days, and the p-value there was 0.036. Apart from female gender, all other variables were associated with prolonged length of stay. When the analysis was then repeated to include variables of age over 65 and age over 70, contrast use was still associated with reduction in length of stay. The second analysis showed contrast was associated with less prolonged length of stay of over 6 days as well.
So turning now to LVEF, recall the number one reason for a repeat unjustified transthoracic echocardiogram was to assess LV function. Overall, LVEF was reported in 81% of patients, either quantitatively or qualitatively. In the contrast versus non-contrast group, LVEF was reported more often, 84% versus 75%. Using contrast routinely on the first transthoracic echocardiogram, irrespective of image quality, increased the likelihood of the LVEF being A, reported by an odds ratio of 1.73, and B, being reported quantitatively rather than qualitatively by an odds ratio of 6.8. The authors provided a supplementary figure highlighting that the LVEF measurement with contrast is more reproducible in ultrasound enhanced versus non-ultrasound enhanced images. So some of the key points are as follows. LV function was the most common indication for a repeat unjustified echo in patients with confirmed or suspected heart failure who were admitted. Over time, contrast use increased. The reduction rate in repeat echoes was sustained. Despite best efforts, about a quarter of eligible patients did not receive contrast on the initial echocardiogram. Lack of resources to inject contrast was the most common reason, a real-world barrier to protocol implementation. Repeat rates of unjustified transthoracic echocardiography decreased when the baseline transthoracic study had A, optimal images, and B, used ultrasound enhancing agents. Optimal baseline image quality decreased the rate by a factor of 2. But routine use of ultrasound enhancing agents on the first transthoracic echocardiogram was associated with a 5-fold reduction in repeat echoes. Recall that there was actually a higher proportion of quality transthoracic echocardiograms in the non-contrast group. This should make the non-contrast group less likely to have unjustified repeat echo, but it did not. LVEF was more likely to be A, reported, and B, quantified, with routine contrast use by a magnitude of 2 and 7 respectively.
So routine use of contrast was associated with about a half-a-day reduction in length of stay and 20% reduced chance of prolonged length of stay. The reduction in length of stay of half a day corresponds to a length of stay related savings of around $700 USD and net cost savings of about $440 USD when we consider the cost of the contrast. And given the very high and rising rates of heart failure admissions in both the US and Canada, this could potentially translate into millions in savings. So moving on to limitations. So firstly, data wasn't collected on whether the unjustified repeat echoes could have actually influenced management. And I think given the multitude of clinical scenarios that merit a repeat inpatient echo, it is challenging to create predetermined criteria that universally classify echoes as justified or unjustified. And so it is possible that some echoes labeled as unjustified were actually clinically necessary. Also, there were differences in the characteristics of the groups, so number of patients in each group, gender, and ejection fraction. However, ejection fraction didn't actually have an effect on length of stay. And regarding gender, there were more women in the non-contrast group, and on the basis of the NIS and of this study as well, female sex actually predicts decreased length of stay. And so equitable numbers of women would have only further validated the benefits of contrast on length of stay in this study. The authors did try to control for confounding variables with the multiple linear regression analysis, but there is always the possibility of other confounders not included in the NIS. The cost analysis didn't take into account the hidden costs of contrast, so time to administer contrast and costs associated with training personnel. And finally, this was a retrospective observational study and does need to be confirmed in a prospective manner.
So moving on to the strengths, we congratulate the authors on elegantly tackling the real-world challenges of diagnostic testing with echocardiography in heart failure. They challenged the traditional way in which contrast is used, core images first, followed by contrast use. These investigators used it on the first study, irrespective of image quality. The investigators faced real-world barriers to contrast use, something echo labs broadly can identify with. They still managed to significantly increase contrast use over time and quantify tangible benefits of early ultrasound enhancement agent use on important outcomes. The simplicity of their protocol is attractive for potential widespread implementation in other echo labs. The cost analysis was conservative in our opinion and potentially greater than estimated. For example, the cost savings related to less transthoracic echo and potentially other unnecessary tests or treatment were not included. From the patient perspective, the personal cost of staying in hospital is not of measurable dollar value. This may be counterbalanced by the cost of the patient from the hospital perspective. That includes the expensive resources to administer contrast and other potential unmeasured length of stay variables. However, on balance, the potential cost savings could be significant, pending validation in future study.
So in conclusion, the use of contrast during first echo at heart failure admission, irrespective of image quality, was associated with an over 5-fold reduction in unjustified repeat echoes and significant reduction in length of stay, as well as reduced odds of prolonged length of stay. This retrospective single center study will require confirmation in both academic and community centers so that we can better understand the potential benefits of routine echocardiographic contrast in heart failure hospitalizations.
So thank you. That was a fantastic presentation. And I think this has some wide-ranging implications. So firstly, I'd like to hear from Tom, Mike, and Mary. Why don't you guys take it away and tell us your thoughts?
Well, I think this is a very important study because it, as Mike pointed out, it looks at the use of an ultrasound enhancing agent on important variables that are critical to us as consulting cardiologists, in that we try to find ways to get the diagnosis as rapidly as possible, especially in a patient coming in heart failure. And I think it's critical to look at this data and make sure that we're seeing exactly what's going on, because this occurred over a period of time and required a lot of analysis. And again, I congratulate both Dr. Hammer and Dr. Ahmed on a very great presentation of the data there. It's interesting to see that this data was collected over time. And that as the years went on, it looked like contrast utilization increased. And the question was, did that impact on a yearly basis then the length of stay? Were you able to see, did length of stay shorten as a function of time in the years? In other words, 2014, 2015, 2016, was there a reduction in length of stay over those time periods that correlated with the increased use of contrast? Or was the reduction in length of stay related to potentially variables that maybe weren't included in Table 6, where I didn't see, at least in Table 6 anyway, where the actual year the echo contrast was given had an impact on length of stay? Could you please comment on that?
Yeah, so I don't believe I saw a change in a yearly change in length of stay over time. I'm not sure. Did you notice that in the paper, Dr. Ahmed?
It wasn't highlighted in the paper, but I think that's a great question.
It's a very good point. Yeah.
And so it'd be something to at least look at, because obviously we're all under pressure. And I think what we forget about here is that how much effort it takes to get a sonographer back in that room. We've had to wait here maybe 2 or 3 days sometimes because there's so much volume involved that it's very hard for a sonographer to get back there. And that could have played a critical role why that patient had to wait in the hospital longer for the follow-up echo, because you can't expect them just to run right back to the room. There's 35 other echoes to do. And And that could have, and I think hospitals forget to look at that important variable is how much it costs to have that echo tech come back, echo sonographer come back and do that additional analysis just because of their time commitment. So I think that's something we really learned from this study is how a delay or having to call that patient back plays such a role. Could you comment why 16% up to 16% of the optimal echoes were considered to have an unjustified echo? Did the physician the reader just not read the ejection fraction even though it had an optimal window? Or was it just inability to still feel like they could accurately see the compacted border?
It's a great question, and we wondered the same thing. It's hard to know the granularity of that detail without having access to the data, but it's a great point. One of the comments that's made in the paper is that perhaps when you have an ultrasound enhancing agent on an echocardiogram, you feel more confident about the borders that you are seeing and more confident in actually calling the LVEF, whether that's visually or quantitatively or in some kind of category. And while we don't have confidence data, we certainly have literature that does support that when agents are used, physician and reader confidence certainly improves when they have to address that very question.
And I'm going to interrupt for a second. I was wondering about this issue of how do you quantify physician confidence or reader confidence, because it's subjective. It probably varies across different personnel. Someone who's been doing this for a long time may be able to be confident about a poorer quality echo than a reader who maybe is just in their first year or two on the staff, who maybe is going to be more hesitant to read things. So I think there's that issue. And the other thing I wanted to ask Mary and Tom, when you have a contrast-filled LV, and if you're actually going to trace the borders and calculate the ejection fraction, I oftentimes have a very difficult time finding the mitral valve annular plane, to know where to end the tracing. And I wonder if you all had any tips on how to, just from a practical standpoint, how to get an accurate tracing of the LV when it's contrast filled. Obviously, the borders, all the trabeculations get filled up, but how do you get that back, that far field well delineated?
Practice. I think when we first started using ultrasound enhancing agents in the general sense, we really struggled with making sure that we had an accurate 4-chamber on axis 4-chamber and 2-chamber views, because you're right, the anatomic landmarks are gone. One of the things that we'll do with many of our junior sonographers is have them compare the clip of the 4-chamber with contrast and the preceding 4-chamber without contrast, so that they can kind of bring those landmarks over in their minds and have a better idea of where that mitral annulus is. That seems to be a pretty effective technique.
Yeah, those are very good points. One of the things, Mike, we have found, and this was a question I also had, is that the time that these data were collected were 2 guidelines documents came out from the American Society of Echocardiography from between 2014 and 2018, and we've gone completely over to fundamental nonlinear imaging instead of harmonic imaging for our analysis of wall motion and regional wall motion, for the very reason you pointed out, is that the far field became difficult to visualize, including the mitral valve plane and the basal segments. With the fundamental nonlinear imaging, or what was previously always called a perfusion imaging mode, but what it simply is transmitting and receiving at the same frequency and looking at that fundamental nonlinear response at a very low mechanical index. It has become a lot easier for our sonographers to see those basal segments and see that mitral valve plane for that quantification of the end diastolic and end systolic volume. So did you all, in your analysis of the data, see a change in the way the contrast imaging modalities were used over the years of your data acquisition?
The paper, or unless I missed it, did not reference whether or not they changed from a low mechanical index imaging to a very low mechanical index imaging. It's a great question and a great point.
Yeah, the other thing that I'd like to just share, so I had two thoughts, and the first goes back to the ejection fraction missing from approximately 20% of the reports. And I have to wonder if the repeat unjustified echoes, evidently the most common indication was for reevaluation of LV function. And I have to wonder if there's a relationship between the reports that did not mention an EF and the unjustified studies for that reason. The second thing that I was thinking about, and again, this is from a sonographer perspective, and I'll share that when the pandemic started, we started training our sonographers to administer contrast and scan the studies. So that's one less person that we would have to send into COVID rooms. And what we ended up finding was that some of the sonographers were very comfortable both pushing the contrast and imaging at the same time, and others were not. And I'd be really curious to see, assuming that this becomes a prospective study at some point in the future, to see what the contrast image quality differences were between when someone different was administering the contrast versus the sonographer both administering the contrast and scanning at the same time. We actually find that we have sonographers who, when they're on call or bedside, will go ahead and push and image at the same time. But when they're downtown where we have the nursing staff, they don't want to because they feel like they get better images. So that might be something interesting for a future study.
Although from an interesting practical standpoint, if you are injecting and imaging at the same time, I suspect that takes you a little bit of time to get your optimal images. And what that allows us to do is maybe get that initial high concentration of the contrast a little bit down in the LV. And if you allow that to happen, I think you do get a little better visualization of the far field when you reduce that sort of apical concentration of the bubble. So that may be another reason why you might find sonographers find that they get better image quality on that contrast enhanced ventricle, because there's a little bit more of a time delay in their imaging.
And there is a learning curve. So I think I find that sonographers initially, when they're starting to administer contrast, will push it a little bit too hard, have to wait for things to clear out, and then they're busy with the machine. And as they gain experience, they get better at the amount that is required and are a lot less prone to the imaging artifacts that we see with too much.
Another interesting aspect of this paper, if we think about heart failure, there's a wide spectrum of heart failure patients, obviously. And I can understand in the HFrEF patient, knowing that ejection fraction is going to be really important. But in the HFpEF patient, the EF is not going to be a major factor in terms of determining outcome or even length of stay. It's going to be the diastolic function and probably other factors So I don't know whether, if I were going to design a study prospectively, whether I would even include the HFpEF patients in this, or I might want to do a look at HFpEF patients separately from HFrEF, because I think most of the findings of this study I would think would be applying to the HFrEF patients.
We have a heart failure specialist in the audience who's asking questions. Perhaps you can comment on that, Dr. El-Mufla, and also ask your question. We've got a really nice audience, so if anybody wants to ask questions, please raise your hand and we'll unmute you. Dr. El-Mufla, can you go ahead?
Absolutely. Thank you very much, Amr, for organizing this, and really enjoyed the talk. I have a question in terms of a small comment about the relevance of ejection fraction. I think now that we're accumulating more data about heart failure medications that are effective in patients with heart failure with preserved ejection fraction, it is more important than ever before to report an ejection fraction. And in fact, the SGLT2 inhibitor trials, the subgroup analyses have showed that above an EF of about 65%, the benefit is quite minimal. And similar analyses have been shown in the Paragon HF trial, where above 57% the benefit has been marginal. So that's again reinforces the importance of reporting the ejection fraction, and that's why I really applaud the authors for doing this study. My question to Dr. Ahmed and Dr. Hammer, well, first, I really enjoyed their talk, and I wonder if they were able to ascertain if the use of contrast has resulted in change in downstream testing. So those patients that have an echo with contrast, are they less likely to get alternative testing modalities? And more importantly, are they less likely to get invasive coronary angiography and other tests? My other question is for the panelists and also for the speakers, is it time that contrast becomes the standard of care? Because I think that we have accumulating evidence that contrast helps, with now in this study, reducing the risk for repeated unnecessary studies, but also improving our inter-observer reliability. And it is very safe, very, very safe. All the black box warning that they're now being, revised. So is it time to change the guidelines now and include it within the standard of care? Thank you.
Great question. So Shaheeda, do you want to go ahead with the first one? Yeah.
Sure. Well, if I may just come back to Dr. Bremer, your question about the LV function. So for the repeat indication for unjustified, it wasn't just LV function. They specified further that it was for LV measurement or quantification of LVEF. So your point is very well taken. And then to address the earlier two questions, thank you for that. They did not collect data on whether or not repeat unjustified transthoracic echo testing influenced their management of the patient, and they did not collect the data on whether or not additional unnecessary diagnostic tests, such as the ones that you referred to outside of echo, were performed or not. There is other literature in the ultrasound enhanced agent area that has done that, but this particular paper did not.
Certainly ripe for another study looking at that, and even a health economics analysis would be interesting. So Dr. Porter and Picard and Mary, did you want to tackle the second question from Dr. El-Mufla with respect to standard of care?
Tom wrote the guideline. He was the chair of the guidelines, most recent guidelines on contrast, so we should let him talk. But if I remember correctly, it's still the indications are for the studies that have limited border delineation, limited quality, not the good quality echoes for which were applied in this study. So Tom, what do you think? I mean, should it be for all, or should it still just be for those who don't have two or more segments?
Right, and I think the reason for that, Mike, a lot was based on we didn't have papers like this one here that has kind of that helps us understand better the clinical impact. We know that imaging-wise that we changed the guidelines from the previous indication was two consecutive segments not visualized, to one where any playtime where you felt you needed to have quantitative data or better analysis of the compacted border, whether that be in ischemia or in the setting of heart failure, where it's critical to have that ejection fraction quantitatively measured. In that setting, we gave that a 2A recommendation to use contrast because of the better reproducibility that has been shown in multi-center studies, and the better correlation with much more difficult techniques to obtain, like MRI. We found that the contrast enhanced echo, especially if used with fundamental nonlinear imaging or very low mechanical index imaging, very closely correlated with the MRI measurements. And so that when it becomes a quantitative question, I think you need to use your most quantitative tools, and clearly an ultrasound enhancing agent allows us to do that. And in this critical setting where it's that first echo on the patient in the hospital where there's limited resources, I think you want to make sure you're obtaining the most quantitative data, even in the preserved ejection fraction patients, just as was pointed out, because those numbers are important all the way up to 65% in terms of whether we think there'll be utility to using agents that are quite expensive, and we want to reserve them for where we think we're going to get the most benefit. And in that setting, again, a very quantitative assessment is essential for not only getting that initial assessment, but also for follow-up assessments when you're trying to determine if there's actually been a change.
I agree with all that. And the other thing to think about is whether the referral diagnosis or the reason that the patient is in the lab is a reason for giving contrast. We routinely will give contrast to patients who are here for their first study for hypertrophic cardiomyopathy, because again, it's the quantitative nature. We want to make sure we have those wall thickness measurements very accurate. But then also with patients with the apical variant, we typically will give contrast to look for an apical pouch. Looking at resource allocation within labs, length of exams, and those sorts of things, I think it might be kind of a heavy lift to convince most labs, especially the smaller ones, that we should be giving contrast with, every patient when we're looking for quantitative data. However, if you can make the argument that in certain pathologies, it's really, really important to rule out certain things, then I think that might be another angle that could be taken.
That's great. I think we might be, looking into that, maybe a paragraph along those lines, perhaps Dr. Porter, with the next update of that now that some of this work is coming out. So we have a couple of more questions in the audience. We have Dr. Sabi D, and we also have a question from Dr. Moss. So we'll go ahead with Dr. D first.
Hi, everybody. First of all, Sabi D here from London, Ontario. Congrats on a fantastic presentation. Really enjoyed it. We're a really large lab here. We do about 20,000 studies a year and 25% use of contrast. A couple of questions I have for you. So the first one is the baseline difference in ejection fraction between the contrast and non-contrast group. 41% versus 47% is what I have here. Is this a real difference, do you think, or is this related to the higher volume that may have been obtained on the contrast study itself? Do you think that difference is robust? And going along what my colleague had asked about EF, in terms of the retest echoes, what was the difference, or probably this data is probably a lot. Do you have any insight into whether the repeat echo, which was done mostly for assessment of EF, showed a higher or lower EF depending on the modality used? And also, was LV thrombus ever addressed in this paper in any way? Because that's a very common indication that we do it here, or somebody may have a subsequent repeat echo done. That's probably the most common one, more so than EF. So just a few questions, and thanks again on an excellent presentation.
Sure, I can comment on the ejection fraction difference. So yeah, so it looks like the contrast group in general had lower ejection fraction. I'm not sure if it was a real difference or not, but it is possible that when scanning someone with a lower EF, the sonographer was more likely to want to go ahead and give contrast and would sort of seek it out more and seek out the resources more. So I think it's possible that there is potentially a real difference.
Anecdotally, I can support that, because if I'm scanning a patient that has a low EF and I'm worried about especially apical thrombus, then I will often give contrast.
And regarding thrombus, I did not see any data on LV thrombus in this study there. Yeah.
That's
and
great.
I think there was a third question.
Yeah, the third question was just more so about the subsequent study, whether there was a difference in ejection fraction, because there was a test-retest variability within all echo that, from normal to mildly reduced is 13%. And when you're doing different modalities, contrast versus no contrast, there usually is a difference in your study. Even if the patient factors haven't changed, it's based on the technical factors of the day, the quality of the image, the method in which the symptoms was traced. So do you have any insight into whether the subsequent study resulted in a lower or higher EF depending on the modality used?
Yeah, I think that's a really great question. I didn't see in the data, if there was a change in ejection fraction on subsequent echo, but I think that would have been really interesting to see.
Okay, great. Thank you again. Thanks for taking my question.
Yeah,
happy holidays, Amr.
Yeah.
Thanks, Sabi Claus. Thanks, Dr. D and Dr. Hammer. Dr. Moss has a question.
Yeah, hi, Rob Moss here from Vancouver. Great presentation. I really enjoyed it, and it's great to see an imaging study that concerns itself with outcomes. I think that's rare, and the authors are to be congratulated. I just wanted to perhaps make a comment and see what the panelists felt about this, but I think the two endpoints of repeat echocardiography and length of stay are connected. So we get this phenomenon of echo, waiting for echo as a barrier to discharge in our institution. And that can sometimes, prolong the lengths of stay by, 1, 2, 3 days. And I think there's maybe a nexus between a non-specific report where ejection's not ejection fraction isn't quantified, that sends a subliminal message of lack of confidence that's picked up by the internist on the ward who orders a repeat echo, and then that feeds back into the loop of, prolonging the length of stay. So I think these variables are connected, which is why I'm not really surprised by the way the study fell out the way it did. But I'd be interested to see what others felt about that perception.
Yeah, no, I think that's a great comment. And I think it could or should tell us two things, or stimulate us to do two things. One is that obviously on that first echo, you need to do everything to that you can to provide as comprehensive a report as possible, and instill in the narrative the confidence of your findings. The other point I wonder about, as we are looking at new innovations in the way we deliver healthcare, if it really turns out that waiting for the echo is really the sole reason for prolonging length of stay, we need to be thinking about ways that we can deliver care maybe outside the hospital. So, can the patient be discharged and then come back 2 days later for that echocardiogram? Or, are there mobile services that could go to the patient's home and provide that? Or can the patient be discharged and go to a waiting area and get their echocardiogram later that day, so that you're freeing up beds? And I know a lot of hospitals are, even before COVID, but obviously now with COVID filling up the beds, are looking for innovative ways to free up beds. And so maybe we, as the people who deliver echocardiography and other cardiac tests that may, make someone stay longer in the hospital, we need to help think about, design some new ways that we can provide care, maybe and free up some of the beds.
Well, I think that goes back to the very point that Dr. Moss raised, is that if we're using everything we have available to us on that first echo and properly using the resource, the most critical resource is the sonographer, and if that is being utilized, if that person is being utilized appropriately right up there front, we should give them the option of being able to use contrast right away. The interesting thing, this was not a prospective randomized study. It was a study that showed also how often it's impossible for the sonographer to get contrast. Yeah. Because although they adopted a policy of everyone's going to get contrast, we literally had thousands of patients still not getting contrast.
3,500 over 9,100, right? So that's going to be 30% of the time.
Mm-hmm. Yes. So this is in a hospital where it was almost mandated. So you can see how difficult this is at this point. It's not our desire to do it, it's our availability. And so we really need to empower our sonographers to be able to give the contrast so that they can do that optimal study. As was pointed out, this is really a problem right now, is getting the contrast, especially in the COVID era, of getting them the things they need to do that optimal study.
And I will tell you, there is a huge barrier at many facilities in terms of having a non-nurse administer contrast agents. Yeah. And there's absolutely no reason for it, as long as the sonographers are adequately trained, competency assessed, and then follow-up education after that. But getting that concept past hospital administration is often very difficult.
That's great. So we have time for one last question, and it's a question from Dr. Michael O'Reilly in the chat function, but we've allowed you to unmute. Dr. O'Reilly, did you want to ask the question? I think it's probably best answered by Mary. So Dr. O'Reilly, would you like to unmute and ask your question?
Sure. So the question has to do with how much contrast to administer. I'm a little bit surprised by the volumes that were put in, because we give here in Kingston, we put 0.3 Cs in between 3 and 5 cc's syringe and inject it. And frequently, I can't see the mitral valve. It's just a shadow in the contrast. So I was particularly, Ms. Bremner, I was really particularly interested in your comment about, you know, how to prepare to contrast and inject it. I understand the concept of the mini bolusing here for what was done, but just interested in your insights about this.
I think actually it probably has less to do with how much contrast is diluted and how much saline, and more to do with how quickly it is injected. Because if it's too fast, you are going to get that shadow and have to wait for the contrast to clear. So as I was indicating before, as our sonographers learn to give contrast, they tend to be nervous about it and give it a little bit too fast. But if you take your time administering the contrast, you often then do not have that shadowing there.
Thank you. You may have just saved me hours of agony.
Happy to help.
Thanks, Dr. O'Reilly, for that great question. And Dr. O'Reilly is sort of our quality control, I was going to say guru, but he's more of a policeman, quality control policeman. So we appreciate his scrutiny. Thank you. And so I'm going to wrap up there. I think this has been a great discussion, and I'm really grateful to our panelists and our speakers today. And this paper highlighted the importance of contrast and the importance that it can make to patient outcomes. And that's what we liked about this paper, because it specifically dealt with outcomes. And we've also recognized that there are still some barriers and some more work is needed, especially with respect to empowering sonographers so that we can improve quality overall with respect to our imaging and reporting. So thanks, everyone. And that brings us to our last piece of our project, of our episode today, where I'd like to share with the audience a little bit about our speakers, Shaheeda and Mike Hammer, for all their work. And I'd like to hear about Shaheeda as part of our STEAM portion. Tell me about what you are interested in with respect to art or a favorite piece or anything like that. Let's hear from you.
I'm actually gonna, if you don't mind, have Mike start first, if that's okay.
Sure, that's Mike. Why don't you go ahead? Yeah.
Sounds good, thanks. So yeah, this is my favorite piece of artwork. So it's actually painted by my aunt. Her name's Deb Jeffrey. And I think she's a really talented individual because she's both a physician herself and she's an artist. So she created this painting using a technique called stain painting, where paints are really thinned down and then allowed to soak right into the canvas. So it's actually an abstracted landscape inspired by the sunsets of Tobermory, which is a beautiful cottage area here in Ontario. And so I have this hanging up in my living room and I look at it every day. And I think what I love most about the painting is the calming effect it gives to the viewer. And really after a long day of work, it just helps me to relax and unwind.
It's beautiful. It's very otherworldly to me. And it almost looks like, you know, makes me think of Mars or something else. So it's interesting how you can get different interpretations. How big is this?
It's big. It's about my height. It's about 6 feet tall. Yeah.
Okay. Wow. You're very lucky to have an aunt like that. That's nice. That's great. So we will end there on the hour. And again, I wanted to thank Shaheeda and Mike Hammer, Thomas Porter, Mary Bremer, and Michael Picard, and everyone who asked questions today. I think this was another successful podcast. And the idea is we want our audience to be interested in the Journal of the American Society of Echo. Please download this paper and take a look at it. It's an important paper. It's available in the December 2021 issue of the journal. And with that, I'll end today's podcast. I hope that everyone has a wonderful holiday and beginning to the new year, and that you and your loved ones all stay safe. So everyone, if you can say a big goodbye to our audience for me, and we'll sign off there. Bye, everyone.
Thanks, Ahmed.
Goodbye. Thank you.
Bye.